and we will go ahead and start. This is Mark East with the South Dakota State Medical Association. Just housekeeping things. First off, for everyone that calls in, we're going to keep the phone lines open where you can ask questions and we can have some interaction and discussion. If you do pick up a bunch of background noise, I may go in and try to close those lines off just to be courteous to our speaker and not to distract others. But again, we try to keep those open for interaction purposes. I'm going to go ahead and ask Stacy to kick us off.
Good afternoon, everyone. My name is Stacy Fredenberg, and I'm the Communications Manager for the South Dakota Foundation for Medical Care. At Great Plains Quality Innovation Network, we're excited to be partnering with the South Dakota State Medical Association to offer a 10-part series of webinar briefs. Patient-centered care topics will be presented in 15 to 20-minute webinar segments, highlighting provider and clinician perspectives while introducing corresponding resources and tools. Today's webinar, Leading Quality Improvement as a Top Performer, will focus on the impact of data transparency on becoming a provider champion. Reach comfort level related to a change requires increased understanding and task repetition. Top performers who provide guidance and support advance quality improvement efforts and enhance productivity for the entire healthcare team. I'd like to introduce our speaker, Dr. Schrader. For 35 years, Dr. Schrader was a family practice physician in Miller, South Dakota, and retired from active practice in August 2015. He currently serves as a medical director for the South Dakota Foundation for Medical Care and a clinical professor in the Department of Family Practice and Community Health at the University of South Dakota Sanford School of Medicine. He's certified by the American Board of Family Medicine and the American Board of Medical Quality, and is also certified as a medical director for post-acute and long-term care medicine. Special interests include quality of care measurement as well as quality improvement programs. He has the opportunity to get involved in statewide programs and task forces involving a trauma system and the acute care of cardiac disease and stroke. He is a member of the South Dakota Diabetes Coalition and actively serves on a number of national and statewide quality initiatives and community advisory boards. So thank you, Dr. Schrader, for sharing your knowledge and expertise with us today. Please begin your presentation.
Well, Mark and Stacy, I appreciate the opportunity to present here. Improvement is one of those areas I've had great interest in. I think what I'm trying to accomplish today is discuss our role as providers and what we do in advancing this process as time goes along. We talk second about the healthcare team collaboration. I can't say enough about the importance of collaborating together, working together. I learned that in my days at the clinic and hospital back in Miller. It's certainly true in my work with the foundation, with Stacy and the crew there, and also the State Medical Association. It's obvious that the future involves collaborating together, and that's one of the things I want to stress more than anything in this presentation today. To talk about a couple of environmental changes and trends that are coming along. I'm going to look at this from a very high level. People talk about a 10,000-foot level. I may be at 20,000 a day, and the air is a little thin up here in some of these areas because they're changing so rapidly. So what I want to accomplish is more an awareness for you than necessarily giving any direction. And we'll go on from there. If we go on to the second slide, then please, Mark.
Guys, I'm getting a slight delay here, so
okay. It's not complicated. There we go. Thanks. So what I want to discuss a little bit is my background. I practiced, as mentioned, in the smaller clinic in Miller for 35 years, and it gave me some firsthand experience about what happens in the process of coding and billing. And in the last 12 years, I've served as the medical director at the foundation. That's given me a whole different insight into areas of quality, from a quality then known as a quality improvement organization, we're today known as a quality innovation organization. And what I saw in my view, but I talk about the collision of two segments. I maybe should have used a kinder term such as the meeting of two segments, but those segments I refer to have become closer than ever. And that's those that are providers as well as those who are the payers and regulators of the services we provide. So we're you know, back in the CPT codes and how we find and document what we do. But when we're to the payer world, they look at that coding and billing, and I can't say enough about the importance of those who do the coding and billing in hospitals, clinics, and other facilities in terms of the interaction with the payers. I'm in regulators because I believe, and oversight because I believe they're starting to play a bigger part in the picture, something that wasn't necessarily true a long time ago, but boards of certification and certainly even the legislature gets involved in payment issues and in dating what must be covered for services, et cetera. When I took on the job at the foundation, there was a quote from the director of CMS, Mark McClellan, who mentioned his view of things as we were talking then about pay for performance, and now it's referred to as value-based purchasing, but that he saw CMS as becoming an active purchaser rather than a passive payer, and I guess that's where things are headed today. So we can go next slide, please. I look at quality improvement just from a basic standpoint. I divided it into three areas. I said, well, what is, how do you define it? And I guess CMS, when I first started, used to call it the best care for every patient every time. I think people have, including CMS, have since that time modified to say the most appropriate care for every patient every time. It's one of the things that payers are now more or less demanding that quality be a part of the services they pay for, and patients have, of course, come to expect it. So, as I like to say, it's often advertised. If you ever look in the paper, everybody you see produces a high-quality service. And I'm reminded of an article from, I think it was in JAMA back in 07, 08, Dr. Don Berwick, who is, you know, real big in quality improvement and national movements, and he talked about physicians particularly being, the title of his article was Adrift on Lake Wobegon. And what implied by that, if you're familiar with the Garrison Keillor story about the mythical town in Minnesota, and the story, of course, was on Lake Wobegon, where all the kids were above average. And there's the implication that we as physicians always, all of us are above average, and those of us who have looked at it from a different standpoint say that may not quite be the case, but certainly if you look at the advertising in the paper, we're all pretty good. How on the quality improvement, you know, those of you who are working in clinics now and still look at your workflow and your process of moving through those patients, and of course understand that we talked about earlier, it is a team effort. It's not just single provider, is those who meet and greet the patient, to the nurses, to the laboratory, to the interoperable records. All of it is virtual to making the care in improving the workflow. I mentioned electronic health records. Certainly, they're the wave of the future, obviously, and I think most, not all of us, are involved in it. That interoperability between them is going to be a factor. Okay. The other area that I want to emphasize, especially this group that's listening, is early adopters. I think those are the leaders that are looked for in the medical field, individuals who will take on this process change and adapt to it and be able to see things that work and don't work.
Okay, sorry, Dr. Schrader. Further in the background, if you I'll go in and I'll just mute all the lines. Sorry, Dr. Schrader, please continue.
No problem. We'll continue on to the why. I can talk loud. Patient-centered care, of course, has become a hot topic again. It's a big focus of CMS. I think those of us who were trained always thought that we were fairly patient-centered, but it's now become one of those that's discussed again. Some clinics that become patient-centered medical homes, PCMH, which is towards the future, a source for reimbursement if your facility can be certified by the NCQA as a patient-centered medical home. So it's, again, patient engagement has become a larger force as time goes on. In the old days, we handed information to patients, their prescription or their telling them what to do, and then sent them out the door until we saw them the next time. And engagement involves the patient and or their families to become more involved in what goes on with care. I myself am now in a course called Better Choices, Better Health. It's a structured process put out for information for families in dealing with chronic disease conditions and hypertension, and just thought I'd go and learn. And it's quite an interesting experience to see how it's looked at from individuals once they walk out of your office. So to be a patient or talk to the patients to find out what's going on. Care trend, I thought I'd mention briefly. I'm not sure where to put it, but I put it under quality improvement. It's one of those things that started out as a hot button back in the late 2008-9 area when it was noted that hospital readmissions every day time were up to 19 to 20% nationwide for Medicare beneficiaries, and of course this caught everybody's attention. And the emphasis that we at the foundation went through initially was a focus on reducing readmissions, but it becomes a bigger item, I think, in that you're talking about more appropriate transfer of information and education along with the patient. That if you're sending them home from the hospital, if you don't, be in place for support once they get home, their chance of coming back for readmission is much greater. So many providers and facilities have now started into a form of for those folks post-acute, so that transition in its whole is a larger topic than just trying to avoid readmissions. Move on, next slide, please. Because it's not a topic that I have a lot of background in, but it's more important with the payment changes and the as discussed earlier. Productivity, of course, is always something that everyone is looked at in terms of their quality and in terms of their compensation, as it were, for what services they provide to patients. And utilization and lately, of course, the topic of overutilization have become much more talked about. The utilization of resources is there, but as we look at the future for fee-for-service, the reimbursement, which much of us are involved in, would appear to be on the decline if you look at it on a national standpoint. A big hot topic coming up recently is overutilization. This is the you will of tests, procedures, frequent referrals, new medications. Things are very easy to order. Whether they have a proven benefit is not quite as certain. And of course, we all are influenced by new technology and demand and sorts of things that come in play. There may be even an element of defensive medicine that plays into this. We order tests just to protect ourselves from later risk of litigation. So that way, but those who pay for it look at it quite differently. And of course, this started the hour of pre-authorizations and denials for payment, and this goes on to this day. But I think overutilization is one of those that's going to be looked at closer in the future. I've been choosing wisely as a resource. It's not something I necessarily promote, and I've looked at what it is as a tool. I initially started by the societal medicine, and it's expanded on and accepted by a number of organizations that the at least questioning of some procedures and treatments needs to take place between the physician, their provider, and the patient to make certain that everyone has the understanding that it is a wise choice to go ahead with this. Again, it's just a discussion process. I just mentioned it because it's in this area. But finally, the business of medicine, this was something that when I started out, as I'm sure a lot of you did, I never looked at medicine as a business. I thought it was calling or a service, and the coding, billing, and the payment took place in another area, and I didn't have to worry about it. But it has become more prominent in our culture, and it's often a difficult, I would even say emotional process to undertake because there's limited resources and time and cultural differences among the patients we take care of. And so when you get to the end game of just pulling care or palliative care, it's not always universally accepted. And it's, I put it, it's almost an ethical question at times, but it involves family involvement, differing opinions, and that's just part, as I say, the business of medicine, if you will. We move on to the next slide, please, Mark, if you would. A little bit on transparency. I know that Dr. Mann talked about this in his presentation last time, and it's certainly something that's come to the forefront in our. There's an interesting article in the Medical Association last November that talked about peer pressure and what was an editorial look at how physicians respond to how their peers are doing. It wasn't necessarily based all on economic issues. It was more based on the cultural or social process that those of us physicians are, I guess we got here because there's some degree of competitiveness, and so when we round at those around us and see that they're doing well, is that peer pressure perhaps to drive us further into the quality world? I don't know. It's an article I found interesting to read. It's not the total answer to things, but it is something that it gets away from just a pure cold hard financial steps of peers and looks at the aspects of it. Reporting, again, is something I went through in my time at the foundation. I put down PURS, which is the Physician Quality Reporting Service, but it started out in my early days as a voluntary reporting process for one or two made and evolved through the years through initiative all the way to a service that CMS allowed for physicians become involved in it. It started out as a small bonus payment if you do it, and now, of course, if you don't do it, there's a mild penalty associated with it. But into the bigger issue that we know now as the macro-MIPS reimbursement issue for those who bill Medicare Part B, and that's something we'll talk about a little bit further in the line. But it has become a issue, and it has evolved. And I've watched it from a voluntary status to now I guess it isn't completely mandatory, but you're going to pay a penalty if you don't involve yourself in it. Physician Compare, and just as a preview to that, one of the I was allowed to do at the foundation is I went to a major development organization called Physician Consortium. It was sponsored by the AMA, and it's gone on now to become its own independent entity that develops quality measures for payers nationwide. I don't involve myself at all in it anymore, but during time, meetings and learned a lot about the process, and one of them that got me interested early on was the Physician Compare website. And whenever it's just in the past, I found that very few physicians have ever looked themselves up on the website or even cared what it said. We were just out here practicing and didn't really care. But I found it interesting because I watched what had happened through my activity at the foundation as to the facilities, the nursing home compare, hospital compare, home health compare, and so Medicare brought along the physician compare, and I don't know how many of you looked yourself up at all lately, but my early days in it about 5 or 6 years ago, I happened when I looked myself up that they had my education and background correct, but it also mentioned that there were 75 physicians within 15 miles of Miller. It's hard to believe that I'd been there 25 years or so and had not run into some of these physicians that were supposedly within a 15-mile radius. What it amounted to is they went by a tax ID number rather than the NPI, so that they're looking at things from CMS is that all these physicians were together in one geographic entity, and of course they weren't. I approached the high-up doc who's the head of Medicare at Dr. Patrick Conway and mentioned it to him. And the principle I'm bringing up is that the sooner this transparency is going to become public, and that a lot of us, and myself included, or at least I can speak for a lot of physicians, that we don't mind data being reported about us as long as it's not too far out of date and inaccurate. And you know, if you publish poor data, physicians will turn away from you in a hurry. I'm certain of that. It can be a very frustrating process. So we can go next slide, please. Payer expectation standpoint, I just mentioned this first. You know, we know that changing methods of reimbursement are going on. And one of the things that comes in line with that is the administrative burden from those office folks we talked about earlier. I found an interesting paper by the American College of Physicians, which through the Annals of Internal Medicine, and it's got a longer title, but it's putting the patient first. And it's a 32-page presentation. I haven't even read the whole thing yet, but it looks rather interesting about aspect of what we can do what you can do in your offices to try and streamline the process, and you know, hopefully you spend more time seeing patients rather than on your laptop entering data that may or may not have advantage of the patient. I mentioned the guidelines and measures. We've talked about them earlier. Evidence-based medicine, of course, is coming to the front. It is, for part, something you can quote. It has a lot of good aspects to it, but it doesn't always approach every aspect, especially for those of us out here in rural area where access is somewhat concerning. Your payment models, actually, what that title refers to the option. If going back to the MIPS, the merit-based incentive payment system for physician fees, one alternatives you can do if you choose or look towards the future when MIPS reporting that can be rather consuming and onerous, one of the options is to form a payment model, which would be a group of physicians and facilities that take care of a population. And there are a lot of things to be worked on in the future on this. These are, as it mentions, it is only a model at this point. It's not something that's definite or that CMS will stand by completely, but it is an approach, as I say, to what looked at in the bigger scale. That's that next term down, the accountable care organizations. Those are entities that don't exist much in the area, but on the coast. I was just at a meeting in the College of Medical Quality a couple weeks ago, and ACOs are big entities on the coast. The population is obviously much greater, and it's just something to think about where we look at a future of, as mentioned, their payments being bundled together and capitation. It's all a change in the model of payment that physicians, if you bill Part B Medicare, are going to be faced with to a certain degree sooner or later. We move next slide, please. So what are some of the challenges that we face? First, in our state, I think you know a big surprise that the workforce, not only physicians or PAs, NPs, advanced practice nurses, but all those involved in the healthcare delivery, what I'll say is the rural area, which is between Rapid City, to be blunt about it. There's movement afoot by a number of entities that the Center for School Medicine has started looking for education, involvement and exposure for students out in these rural communities. Look towards the future where the workforce is going to be. I was that went on through the from the American Hospital Association, but also done by local our state by a group with the Hospital Association, and it was termed basically a study of vulnerable communities. And for the Northern and South Dakota, those are communities that have existing small hospitals or clinics, and what is their future as the payment system goes on. It's an interesting time. There's a white paper out on it from both a national and state standpoint as to where care to be delivered in these rural areas in the future. Worth mentioning is the burnout. I mentioned that because I talked about the fourth aim. I've seen a lot of calls about this recently. You know, there's the three aims of CMS, which are better health care and lower cost. Well, a lot of folks about it in a full name, and that's keeping providers healthy and on job. At the rate things are changing, burnout is certainly a consideration. Comments on some of these other things. Patient literacy is a big issue. It was obvious as we looked at it from our foundation standpoint and from a number of other looking at it, that sometimes patients don't completely understand what we're trying to deliver to them as providers, either because of their culture, their environment, their ability to understand or follow directions. It involves extra effort oftentimes on the part of the community around them to make certain that patients understand what we deliver to them. I put myself, when I was reading my last bill from Medicare, now that I'm Medicare age, I looked at and I found myself quite illiterate in terms of being able to understand the billing and coding process of Medicare itself. So I'm a little bit lit myself in that regard. Patient adverse outcomes are mentioned. I won't go into detail. It is one of those things that has always been a stress from CMS, and we again look at lots of programs coming down the line for medication safety and avoiding care-associated, acquired conditions, things that can be possibly changed or averted if we put ourselves more on the focus of patient safety and avoiding errors or distractions. It's a hot topic issue. The payment structure, we've talked a lot about MACRA and MIPS, or discussed it. Another area that may concern in the future that I've paid attention to, and that's Title 19 funding. There's more discussion from the federal government that block grants may have approaching this in the future, and that may have some financial considerations for those of us that take care of Title 19 patients, especially in rural areas in state. It's something to stay in tune to. Move on to slide 8. We'll close out here just with some of the challenges that I see, and one of them I've been probably as guilty as anybody about is a silo mentality, as I mentioned. We oftentimes just think of ourselves as our own little clinic, our own community, our own hospital, and don't look around us at what it takes to collaborate and combine with others. Someone put it well, improve quality is a team sport, and it's something we just can't forget about in terms of the future challenge. The one thing I would stress is for individual providers about maintaining some degree of involvement in some type of organization, whether you're associated with a healthcare organization or a specialty or committee or whatever it takes. It's going to fit in with this collaborative effort, and so later we're all going to be accountable for what we do. Right? We talked about the transparency issues coming into and sooner or later we're going to have to be able to for the care that we deliver, and I think going on maintaining involvement is important. So how to adapt to these changes? If I knew the answer to that, I'd probably be speaking to larger groups than this today. I think it's important that we keep in mind that there are changes coming, and that some of them are cultural, as we mentioned. A lot of them are certainly financial, as we mentioned, and there may even be some structural changes that perhaps, like I mentioned, with the vulnerable communities, maybe there's discussion of whether create us hospitals, which of course are many of the 35 or 6 in the state, many of the smaller communities, whether they will exist in the future. So that's what I looked at as a structural change, and certainly how we adapt to it has a great effect on our practice and our community. And bottom line, the only thing that's constant in healthcare is change. I'll happy to answer questions, or more importantly, refer you to resources that we at the GPQIN, Great Plains Quality Innovation Network, have, because we're happy to, if we can't provide the information, at least find you with someone who can. So we answer questions.
So just as a reminder, all phone lines are open. Please, if you have any questions, go ahead and ask. So checking the chat box too, I don't see any thing listed at this time.
There's my contact information there. If you come up with questions or thoughts, or always happy to take them.
I'll throw out one last call, then I'll turn it over to Stacy to wrap things up. Any questions for Dr. Schrader before we wrap up today? Okay, Stacy, I'll turn it over to you.
One for joining, just a reminder that the next webinar is in 2 weeks, which is April 25th. And we're going to be starting a series focusing on patient engagement, going over how to help them do management, as well as tools and resources that are available. So you can go onto the SCSMA website, register for those webinars as well. So thank you all for joining this afternoon, and as Dr. Schrader said, feel free